Okay, well, thank you, Julio, and thank you for inviting me. And it's great to be here in circulation again. What I'd like to do is review with you our experience using these molecular studies for rapid diagnosis, plus biomarker procalcitonin, and the influence of our antimicrobial stewardship team on the impact of treating community-acquired pneumonia. Actually, other than COVID and being involved in developing policies for COVID at our institution, I've been spending about half my time on antimicrobial stewardship. Well, anyway, let me just proceed then, because some of this is going to be deja vu, because at a prior CAPL meeting, and I think it's 5 or 6 years ago, I presented a study that actually Julio and I and Donna Mildan from New York proposed, and actually we applied for an NIH grant. I will tell you, we were not funded, but actually it was a study to look at that time, the available rapid molecular studies and see if we could actually have targeted antimicrobial therapy for the majority of our patients based on the results of those, quote, early results of studies. And within disclosures, no problem. Next slide. No, wait. Okay, fine. Well, this is the presentation I gave at CAPL, as I said, several years ago, and it was a 3-center study. And you can see the primary investigators of each center. So our summary of Project AIM was to evaluate the feasibility of a prospective clinical trial that would study whether adult patients hospitalized for CAP can safely be treated with targeted antimicrobial therapy, pathogen-directed therapy, if you will, early in the course of management. We would hope that eventually this could lead to diminished antimicrobial exposure, therefore resistance, reduce adverse events, reduce disruption of the microbiome, which we're all concerned about, and then cost. And we were going to assess the clinical utility of these molecular tests in addition to our standard other tests. I mean, we have urinary antigens, sputum cultures, et cetera, on reducing antimicrobial use. So the tests that we are going to evaluate are all showed here. The molecular test, of course, was going to be well, I shouldn't say of course, but it was going to be the multiplex respiratory PCR panel BioFire. As far as primary outcome, it was going to be how many we were able to identify a pathogen and then give specific targeted therapy within 24 to 48 hours. And remember that when I go to the last slide, 24 to 48 hours. And then we had several secondary outcomes, but one would be, is there going to affect on clinical response? I already told you it wasn't funded, right? So what I'm going to tell you now is we applied this sort of approach to our general practice over the last 3 or 4 years. We have been a proponent of the benefit of procalcitonin, at least helping us with the decision to stop antibiotics. This is a first sort of a pilot project we did back in 2012, so it's more than 10 years ago. But looking at patients in our ICU, we have looking at the effect of the procalcitonin when we first introduced it in our laboratory, and we gave our critical care staff sort of education how to interpret it, but we didn't oversee the use of the test and interventions. We just told them what the recommendations are. And so based on that, and we just had 50 patients who were, we did the procalcitonin on, and then we had 50 controls, and we found that with the procalcitonin, we were reducing in our ICU, and basically it says sepsis or pneumonia. Almost all these were pneumonia. But at any rate, the effect was that the duration of antibiotics was decreased by 3 days using the procalcitonin. Because prior to this, I mean, now we had sort of an objective test that supplemented the clinical judgment, but in many cases, the clinical judgment was, I think we could stop antibiotics, but I'm nervous to do so. Well, now we had this test and it says, yeah, you can. And so anyway, reduced the duration by 3 days, duration in the hospital by 4 days, because oftentimes if they weren't on antibiotics, they weren't needed in the hospital. We reduced readmission almost, it was almost statistically significant by 16%. And very importantly, we did not harm the patient, at least by mortality, because that was a concern by our intensivists that, well, look, if we stopped antibiotics too early, we would have a detrimental outcome. And we didn't do that. Now I'm going to go closer because I can't see it over here. But so anyway, now I'm going to show you some of our application of what we wanted to do with that particular NIH applied study. So this is looking at our experience with the use of the molecular test and the procalcitonin and the antimicrobial stewardship team intervention. And so one of our thoughts was that if you get a virus identified with a molecular test and you've got information that suggests you don't have a concomitant bacterial infection, and of course this is pre-COVID, and if it's not influenza, there's no need to give antibiotics. So we looked at patients, and the algorithm is right here. And I'm going to show it. I'm going to blow it up in just a second. But basically what it says, if you have a patient coming in with clinical pneumonia with a pulmonary infiltrate, you have a positive test for a virus, then you look at the procal, and the procal is really low. And right here, it says less than 0.1. And, you know, by 24 hours, if you have a negative blood culture, a negative urinary antigen, negative sputum culture, if you have sputum, which is the minority, obviously, then you stop antibiotics. Okay. And so we just looked at that. And so what I'm showing you in this particular table is if there, and this is a small study, this is sort of just our initial experience, but if there was a virus isolated, the mean duration of antibiotics after the test result was 1.6. If a virus was not isolated, obviously you're going to continue antibiotics. But if a viral virus was isolated and you had low procal, and here it's 0.25 because that's the consensus of what people use, it would reduce to 1.2. But if we added the impact of the antimicrobial stewardship oversight, we further reduced it to 0.6. Now, remember, this is pre-COVID now, and these are the viruses that were predominant. Now that we identify these viruses, I think we became more aware of the importance of viruses, particularly in adults causing pneumonia requiring hospitalization. Many studies, including the EPIC study, Rich was involved in that, about 24% of patients in that study had etiology only due to viruses. One thing that was interesting to me was, you know, the number one was metapneumovirus, and many of these cases of metapneumovirus really looked to me like bacterial infection, acute onset, you know, lobar infiltrates. I mean, it was amazing. But at any rate, so what we found, as I said, is that using the molecular test, the procal, we could reduce the number of antibiotics, but that the stewardship helped with that a lot. The results of respiratory panel and the procal led to decrease in antimicrobial duration and length of stay, and but it was most profound in patients in which the antimicrobial stewardship team intervened and gave recommendation. So this is our sort of algorithm. So if you have a viral PCR, now initially it was just, this is when we just looked for influenza. Of course, our initial influenza test did have RSV as well. And if it was positive and if the procal was really low, we would definitely stop antibiotics. If it was less than 0.25, we would look at that carefully and usually stop antibiotics as well. But the majority of these patients had procal less than 0.1, which made it kind of interesting. So at that time, we said, well, the antimicrobial stewardship team is important because you can do these tests, but if you don't intervene on the basis of the results, you really don't get much difference in behavior or practice. So then going on further, this is the next year, this is 2018, again, pre-pandemic, looking at our experience. I'm just going to focus on community-acquired pneumonia here. And these are, again, looking at patients who have low procalcitonin, have a virus isolated. Most of ours had a procalcitonin less than 0.1, I mean, almost 80% here. And then in these patients, they had a mean duration of 2.6 days. Readmission rate was somewhat less than our usual readmission rate for pneumonia. And mortality rate was, and again, when you look at the average age of 74, this actually is lower than the mortality rate for bacterial pneumonia. So what we found was that by using this, we could reduce the duration, you know, from the usual recommendation from our guidelines, at least at the time, was 5 days. We reduced it to almost half of that. And we did not seem to harm the patient again, at least based on the two metrics that we follow, readmission rate and mortality. This is just an example of a patient, 61-year-old female, did have low white blood count, which was one of our parameters that we followed. I mean, if the white count was below 11,000, if it was above 12,000 or above, we were a little concerned about that as far as stopping antibiotics. But a lot of these patients with viruses just had relatively lower white blood count. And I thought you sort of saw that too, didn't you, Dr. Shindo? But at any rate, patient was admitted because of the pulmonary infiltrates, so was placed on levofloxacin. But then our antimicrobial stewardship team, we evaluate all these patients the next morning. And we saw this patient. So we said, well, let's get the multiplex panel. And it was positive for metapneumovirus. The procal was really low. We told them to get that. So we said, stop antibiotics, which they did. And they discharged the patient because she no longer needed any oxygen. And, you know, she just spontaneously, well, not spontaneously, but resolved the infiltrates. And then talking about SARS, that Dr. we just were discussing, again, we sort of looked at our experience based on our observations and the utilization of procalcitonin, because if you have SARS, now we've already done the viral test. Either we do a fourplex, which, you know, looks at influenza, SARS-CoV-2 and RSV, or we do the respiratory panel, which looks at about 10 different viruses, as you're aware. But then if you look at the effect of the procalcitonin, you can see if it is less than 0.25, less likely to get antibiotics. I mean, most of the patients before this, everybody with a positive SARS-CoV-2 test received antibiotics. We got at least down to about 50%. Now, if it's over 0.25, 80% received antibiotics. It did have an impact on duration, 2 days of antibiotics versus 4 days, and then the length of stay, it had a impact as well. I want to point out that I'm part of a panel with Infectious Disease Society of America and a CDC. They're putting together an algorithm for community-acquired pneumonia, primarily for use in non-tertiary hospital settings. But if you have the diagnosis, clinical diagnosis of community-acquired pneumonia, it goes through decision analysis, how you might admit a patient. But if it doesn't have the yes or no's, but this would be yes. And if you have an inpatient admission, then we just divide it into severe versus non-severe. But I want to point out that we're recommending that if it is available, and you have a antiviral therapy, well, is indicated if you obviously have influenza or COVID-19. But we also are going to recommend, considering whether or not there's a copathogen based on a procalcitonin and potentially stopping antibiotics. And so if we look at recommendations from the Infectious Disease Society of America as far as the use of these molecular tests, this is a viewpoint paper that came out, well, I guess 3 years ago now, but I just want to highlight the last part of this column here, the definition of optimal testing algorithms and antimicrobial stewardship interventions. And so what they're concluding is that studies combining host response signatures, biomarkers, with pathogen detection, which would be the multiplex PCR test, and active antimicrobial stewardship, and that prospective studies need to be done. Now, there are several studies looking at the benefit of the multiplex PCR test showing you have an increased yield. But we have a paucity of data looking at the evidence for clinical response, and that's what we really need. And that's what we wanted to do in our study. Now, this is interesting because I came across this paper from Norway, and it's really describing a prospective study that is ongoing at this time. It's a randomized clinical trial, standard of care methods, which would be, your sputum cultures, whatever, blood cultures, versus testing by the rapid multiplex PCR, which is the biofire that they're going to be using, or they are using. And the hypothesis is proportion of patients treated with and shorten the time to pathogen-directed therapy, and hopefully to reduce unnecessary use of broad-spectrum antibiotics. And so their outcomes, and this is why I say remember 24 to 48 hours, their primary outcome was similar to what ours was going to be, and that is the ability to give pathogen-directed treatment within 48 hours. They're also going to look at the specific time. They had actually 21 different secondary or quantitative outcomes, which did include assessment for mortality at 30, 90, 1 year, and 5 years. So this study is going through this year. It's from 21 through 23. So we'll see if they can show some benefit in this randomized clinical trial. And that concludes my presentation. I'm not speaking Spanish here.
Very good. Then this is another area of a lot of controversy. But it's interesting that we've been trying to do, everybody has been trying to do this study for years, but nobody was able to get funded.
Yeah.
We're still, okay, discussion, yes.
So nice presentation, Tom. So I guess this is a question about the level of evidence needed to recommend things clinically. So there's a very big difference between saying in the setting of an acute pneumonia with pulmonary infiltrates that a test allows you to never give antibiotics, and an approach that says you can give antibiotics, but if, you know, at 24 hours, you're not headed into the ICU and the tests haven't found a bacterial pathogen, you can stop antibiotics. I very much support that second approach. Mm-hmm. I have grave concerns about some of the approaches of wanting to say never give antibiotics, because there's abundant evidence of co-influenza and pneumococcal or staph with low procalcitonins. And so I'm really trying to tease you out around how strong does the evidence got to be for each of those two different, very philosophically different approaches.
Well, Grant, as you know, as co-chair of the most recent guideline, that was a discussion, of course, but that's pre-COVID. Your guideline was pre-COVID. And no, I agree with you. I mean, we feel very comfortable in the targeted antimicrobial therapy based on information we have at 24 hours. We're not promoting, to withhold antibiotics. I'm just showing you what our observation was as people were using this without even antimicrobial stewardship intervention. There seemed to be a reduction in the use of initial antibiotics when they truly, well, there were several factors here, Grant, because not only did they have the positive test for the virus, in this case, SARS-CoV-2, they also had, low procalcitonin, and a white count that was below 10,000. That was another thing that I didn't point out there, where they might, most of these patients did not require supplemental oxygen anyway, so they weren't quite as sick. And if they had a consolidated infiltrate versus maybe just a patchy ground glass infiltrate, they would always give antibiotics as well. So it's a little bit more nuanced than what I'm showing you here. But I do agree, and what we're trying to promote is that second process that you just mentioned, that we can hopefully at 24 hours with these newer techniques, provide targeted therapy, hopefully, and we'd like to see a clinical response of the patient, a patient relevant response, not just the fact that we can change antibiotics. Does it make a difference in the patient? And that's what we're hoping for. I think the ability to identify a pathogen at the point of evaluation, however, can be extremely helpful. I mean, we find it much more helpful in nosocomial pneumonia, because if we identify, from the multiplex PCR, for example, Klebsiella, but we have gene markers that we evaluate. So is it CTX positive? Well, we're going to change our antibiotics versus TCX, not, and that's not absolute either, as we know that those aren't 100%, but I agree with you. The second part, definitely. I don't think we're ready for that first part, but maybe we will as these tests become more evaluated, and that's what we need. We need better clinical response with the use of these tests.
At this moment, do we need a clinical trial because again, we are going to start antibiotics. The clinical trial we want to do was what you're doing, and we're also doing this with antimicrobial stewardship. The patient is admitted with identified viral pathogen, and then you meet all these criteria in the first 24, 48 hours, we discontinue antibiotics. We assume this is a viral pneumonia only without superimposed bacterial pneumonia, and then we discontinue. Now we are doing, a lot of people are doing this. Do we need a clinical trial at this moment?
Well, to put in the guidelines, we do.
Well, no, but I mean, the guidelines is one thing. I'm asking the group here, do we need a clinical trial at this moment to, or we just say, or we just recommend, you identified influenza, or you identified whatever, and the blood culture are negative, whatever is your criteria, you identify all these criteria, discontinue antibiotics. Essentially, do we have enough data in 24, 48 hours to say this is a viral pneumonia without superimposed bacterial pneumonia, without a co-infection with bacterial pneumonia, treat as viral pneumonia, stop antibiotics?
I mean, thank you for your talk. I think this opens up the questions about the role of procalcitonin. And I was thinking on the other side of it, which is when it's positive in the setting of viral infection, we actually don't know what it's doing, what it's telling us. And we've shown in our single site that in influenza and also now more recently in COVID, that procalcitonin can even go up based on SOFA scores or even severity of disease, not necessarily just bacterial infection. And so the question is, even how do we pick that timeline, 48 hours, right? When that bacterial infection is going to happen. And the other question is, do we need additional biomarker clinical markers to tell us you have a bacterial infection? I think I'm just curious.
I think there are going to be more specific biomarkers that are being evaluated, and that will be helpful. I mean, we know that there's a lot of confounding issues with the procalcitonin, right? And that's why, we do procalcitonin on admission and then 24 hours later, just to see, if it was going up or whatever. We know that SARS-CoV-2 in and of itself without bacterial infection can increase the procalcitonin. But again, if it's very low, I mean, we feel a little bit more comfortable. But again, it's like a gestalt. I mean, we have the clinical judgment issue, and then we have these objective tests that sort of support our clinical judgment. And, hopefully, for the last 2 decades, 3 decades, I mean, Rich and I were on the old guidelines. We really promoted empiric therapy, right? And so we were treating all of the likely pathogens. Do we really need to do that? If we have the tools to allow us to do more specific path, is that going to be better for the patient? And we don't have the evidence yet. We've got some of the tools, we just don't have that clinical.
I think that we need to push agencies to fund and study like this, or do we just say we have enough experience that you don't need a clinical trial? This is going to, now we understanding that yes, procalcitonin could be high in COVID, and then you are going to use antibiotics because you don't know. The question is, and then how many criteria do we need to have for everybody to feel confident? Any other comments?
I think you have to turn that around the other way, in that there is no way that we could recommend that clinicians are wrong to de-escalate under that setting. I mean, there is no evidence to say that they're wrong, and in actual fact, they prove every day they're right. So I don't think you need a clinical trial to prove that, because the converse is equally true. But I think for me that the level of evidence you would need to prove the first proposition, that you don't give antibiotics in any setting, and I think that very first wave of COVID was very unusual, okay, because no one was seeing anything else. So, but now you need tens of thousands of patients, I think, to convince yourself that withholding antibiotics is worth that one death that you might see, for me.
I may say that withholding antibiotics at this moment from the beginning, we are not there. I was just even considering just in 24 hours stopping antibiotics. I don't even, but again, this is minimal experience. I say, well, we identified the patient and we stop antibiotics and nothing happened. Yes.
So none of this occurs in a vacuum. So the ED, their orientation is get this patient out of my ED, and I'm going to give them a dose of antibiotics. And so in my mind, this is a moot point. They get one dose of antibiotics no matter what, if they're going to be admitted. And the procalcitonin and CRPs and all of those have just really not made it into the ED departments in very many places to avoid giving that first dose of antibiotics that they're graded on in the past. So to me, the big issue is trying to stop that ongoing antibiotics. And I think it's very reasonable to turn the question around and say, do you need additional antibiotics, period, in these patients? Because a very low procalcitonin it's very unlikely to be bacterial. And if it is, I'm not even sure antibiotics make a difference in mycoplasma. So I think the horse is out of the barn. You don't have enough places with clinical equipoise, and it doesn't even depend on antibiotic stewardship people. Our hospitalists in our hospital don't have enough beds to admit to, so we're holding patients in the ED. If you've got a CAP patient who's got a low procalcitonin, positive viral, they're sending them home. The issue is not even further antibiotics, it's getting them home without anything, because we need beds, and our hospitalists are not going to go back to the, to an RCT. They're not going to pay any attention to an RCT because they've got lots of clinical experience that says this is safe. They can get them out. They don't get them readmitted. And, the clinical equipoise, I think, is gone, for a non-ICU floor patient, kind of the whole group that you described here.
Good. Okay, well, thank you very much.